Okay, nampak kan? Okay, nampak. Uh, okay. Okay, so saya start Doktor. Okay, Assalamualaikum. My name is Ikhwan, my Ikhwan Medikify, which number 1819869. So I present about the bronchial asthma. Okay, so for the content of this presentation, I will present about the definition, pathophysiology, history taking, clinical features and investigation, management, and also complication of asthma. So what is asthma? Definition given by National Asthma Education and Prevention Program, or NAEPP. It was defined as a common chronic disorder of the airways that is complex and characterized by variable and recurring symptoms: airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. The interaction of these features will determine the clinical manifestation and also the severity of asthma and response to the treatment. So, about the pathophysiology of asthma, there are three main points which we need to know, which is cause of three. Okay. Three points, which is first, hypersecretion of mucus, airways muscle contraction, and also swelling of bronchial membrane. So this this diagram in the right here conclude all the pathophysiology for all these the 3 points. So uh, there are ways to acquire asthma, which one of them is by the response of the T helper 2 cells. This T helper 2 cell will be triggered by hormones, inflammation, allergens, or exercise and inflammation, which was caused by airway epithelium damage. So this response will cause the T helper 2 cell to release cytokines such as interleukin 5, 9, 13, and 4. So interleukin 5 will we will move to all the pathway here. So one of them is interleukin 5 will activate the eosinophil for the proliferation and cause eosinophilia. So this will contribute to airway inflammation and constriction, and this will cause asthma. Okay. Other than that, there's also interleukin 4, 9, and 13, which this pathway will induce B cell to produce IgE, and then this IgE will then this IgE will then attach to mast cell, so that the mast cell will produce histamine, prostaglandin, and leukotrienes, which will then lead to bronchoconstriction and will cause asthma. And then lastly, for another pathway, which is for infection, this pathway will cause asthma by the production of interferon gamma, which are produced by natural killer cell and CD4 and CD8. This it will also cause the interleukin 27 to promote, and then there will also be interleukin 27, which will promote the production of interferon gamma by the NK cell, and then will induce the airway inflammation, and then will cause asthma. Okay, then next we move to the history taking of asthma. So there's a few there's not much symptom that we can there's not much symptom that we can say from history taking, but there's a few, and you can later know it later history. So the among the symptom is cough, wheezing, shortness of breath, chest tightness, and recent chest infection. So regarding the symptom, what you need to ask is the pattern of the symptom, which is if maybe the symptom usually occurs nocturnal, which is at night, or maybe the symptom exacerbate during early morning, and then the frequency of the symptoms, onset of the symptom, and the duration of the symptom. So usually the symptoms, all the symptoms will occur at once. For example, if maybe for example in a situation, an infant having a cough, and then about 5, 10 minutes or 50 minutes later, the baby will then have chance of death due to the cough. So that's, and then for having chance of death, the baby will have wheezing sounds. So that's why you can say the usually symptoms all came at once. Then we can ask the parents about the triggering factors of the chance of death. So so we can ask the patient, the parents, if they know maybe the patient are exposed to this, which is maybe exercise, like maybe the child recently just running around the house, and then after he finished running around the house, he suddenly have shortness of breath. So we can say that maybe the trigger factors of his or her shortness of breath, and then maybe furry things like pets or carpets that have fur. Then we can say that it was caused by this, and also dust, cold air, and smoke. Then we also need to ask about the risk factor of his asthma. For example, if maybe we can ask if the patient have eczema or not. If maybe the patient have eczema, then we can say it is an atopic disease, because people with eczema has risk to have asthma. Or maybe we can also ask the family members if the patient have family members who has eczema or asthma, then we can say the patient has risk to have asthma. And then other than that, we can also ask response to the patient. If maybe the patient have previous shortness of breath, and for example, the patient have this the symptom was reduced from inhalation of apa tu namanya, inhaled corticosteroid. So maybe we can say if the symptom are relieved, maybe it was because this was asthma and it was relieved by the inhaled corticosteroid. So in diagnosing asthma, I have there are a type of index that we can use to predict if someone may have asthma. So here we have positive predictive index and negative predictive index. So if the patient have positive predictive index, the patient has 65 chance to have asthma by the age of 6 years old. But if the patient, if there is negative predictive index, then the patient may has 95% of not getting asthma by the age of 6 years old. But the patient may still have asthma, but this is just for prediction. So to categorize a child as a positive index, the child need to have, the first criteria is to have 3 wheezing episodes per year. If less than that, then maybe it is not negative lah. So if it is 3 or more, then another criteria that the child need to have is either 1 major criteria or 2 minor criteria, which is major criteria is eczema or parental asthma, and for minor criteria is allergic rhinitis, wheezing apart from cold, and also eosinophilia. And then after asthma was diagnosed, we need to determine the severity of the asthma by following the table that I have shown before, shown here. So here you can see that the asthma, how to determine severity. First is intermittent asthma. You can read the criteria letter. So, and then we have persistent asthma, which divided into 3: mild, moderate, and severe. And you can read the criteria letter. But what important here is the severity of the asthma will determine how we manage the patient, like how what is the medication that needed for the patient, and also uh, if maybe the patient the prognosis of the patient nanti. So and then next we move to the clinical features and investigation. So as you all know, in PE we will start with general examination. So in general examination, firstly we will check if maybe we will expect maybe the patient have respiratory distress if the patient apa namanya recently admitted. So if maybe the patient are recently admitted, then we can expect the patient to have symptoms of respiratory distress, which is use of accessory muscle, subposterization, and also nasal fluorine. And then the patient at the time may also have tachypnea, cyanosis, eczema, and wheeze. The wheeze that I mentioned here is not wheeze that we can hear through the stethoscope, but you can hear without using stethoscope, like that you can hear it from beside the bed. And then we move to the inspection. There's two expected findings during inspection in patient with asthma, which is first, Pectus carinatum, or other names for this is pigeon's beak. You can see later in picture how the chest deformity of the chest. You can see it will shape like a pigeon's beak, and then also Harrison sulcus. You can see later in picture there's like a lekuk ataupun dent you can see below his subposterior region. Okay, and then next, in palpation, we will expect the patient to have reduced chest movement, and then a reduced focal parameters, and also increase anteroposterior diameter, because you expect the patient have hyperinflated lung. And then upon percussion, you will expect to have hyperresonance during percussion, because the same reason which the patient may have hyperinflated lung, so hyperresonance may be heard during percussion. And then lastly, for clinical features, during auscultation, we will hear reduced breath sound, which we can try to compare with normal breath sound, and then prolonged expiratory phase, expiratory wheezing, and also fine crepitation. So you all can try to search for the sound for wheezing by yourself by using YouTube, because I tried to put the sound here, but was not successful. So you can try using YouTube to hear for the sound of wheezing or crepitation later. So this is the picture that I want to show you. So the first picture on the left side one is the picture of cyanosis. If maybe the patient took cyanosis, then you can see here in the picture the mouth and the tongue have a bluish discoloration. So then we can see the patient has central cyanosis. And then the second picture is a picture of eczema. So maybe if we check during the general examination, you see the patient have this kind of skin condition. So then we can say that she or he have risk of asthma. Then third picture is the picture of Pectus carinatum, which is pigeon's beak. We can see here in the picture it has like triangle shape, like a big shape here, because it was caused by asthma. And then lastly is the picture of Harrison sulcus. You can see here there's a dent or lekuk. You can see here in the picture. Okay. Okay, so then next is the investigation for asthma. So there is no specific investigation for asthma, but we can use this as among the ways to try to differentiate with other diseases like COPD or maybe other diseases lah. So here first is we try I divided into two. First is by pulmonary function testing and also other. So by pulmonary function, we can first try to use spirometry, which we can measure the forced expiratory volume in 1 second, and also forced vital capacity. And using this measured value, we can find the ratio. If the ratio is less than 0.8, then we can conclude that there is an obstruction. It will maybe due to COPD or maybe due to the mucus from the asthma. And then next test, we can use peak expiratory flow, which we usually have a normal value for each age, and if the patient have lower result than normal, then we can suggest it may be caused by asthma. Then another pulmonary function test that we can do is exhaled nitric oxide, which we use this device. So this test does not exclude, does not say that the patient have asthma, but if the patient has high value, then it may be due to the eosinophilic inflammation, which will cause asthma. So this can help us in treating the patient according to his information. Okay. And then other tests that can be done is blood test, which we can also say full blood test. We can try to look for maybe all the white blood cell, eosinophilia. But for white blood cell, you can say that if the white blood cell is high, maybe it can be due to infection. But if the eosinophilia is high, you can say that may be caused by allergic asthma or parasitic infection. And then we can also do skin prick test or allergic test. This is to confirm if these sources of breath are caused by the suspected allergic triggers. So by doing this test, you can know if the patient really are allergic to these triggers. Then we can also do imaging of chest X-ray, which we can see the picture of hyperinflated lung. So next is the picture. This is the picture of hyperinflated lung. I have forgot to put the normal one. So usually you can see the difference between the normal and hyperinflated by usually the hyperinflated has more like darker picture because it has more air than normal. So compared to normal, the hyperinflated one will be darker than normal. And then we will move to the principle of management. So to manage the patient, as you can say here before, after we assess the asthma, we assess the severity, and then we assess the asthma control in about 4 to 8 weeks, like follow up, and then give the medication according to the severity of the asthma, and also we educate the patient regarding his sickness. Maybe we need to teach them how to use the inhaler, and maybe ask the patient if maybe they need to like maybe if they are in school, maybe they can say something to the teachers if maybe they are about to do vigorous activity lah. So okay, these are the table below are the ways how to give medication for asthmatic patients. So first is for intermittent asthma, we can give intermittent short-acting beta agonist. So the patient will usually take the short-acting beta agonist if the patient have asthma. And then for mild persistent asthma, you will give the patient low dose of inhaled corticosteroid, or about 100 to 200 milligram per day, or leukotriene receptor antagonist. And then if the patient have moderate persistent asthma, then we will give the patient moderate dose of inhaled corticosteroid, which is about 200 to 400 milligram per day. And then lastly, if the patient have severe persistent asthma, then we will give the patient a moderate dose of inhaled corticosteroid combined with the leukotriene receptor antagonist, or maybe we can give them high dose of inhaled corticosteroid, which is about 800 to 1,200 milligram per day. So, as I said before, we need to assess the asthma control. So this is how we assess if the asthma is controlled or not by using based on this characteristic. So there's a daytime symptom. If maybe the daytime symptoms are like none, or if it is well controlled, then it will be none or less than 2 times per week. Okay, you can all read lah the all the characteristic and uh, the the control over not. So okay. So and then lastly, I will present about the complications. So in daily life, how asthma cause complication is firstly the patient will be easily fatigued. Like after a few minutes of vigorous activity, then the child cannot do more vigorous activity. So he will be easily fatigued, and then this will also can cause it to interfere with works and school. Like normally, like in works, sometimes we must do like very vigorous activity. So with asthma, it will interfere with his or her works and school and cause them to have difficulties. And this can also will cause psychological problem, because maybe due to interference with work and school, then the patient may have anxiety or depression due to his failure to do things normally. And then there are also side effects for using the from long-term use of the medication that he has been given. So among the side effects that I've known is maybe mood change, forgetfulness, hair loss, bruising, tendency to have high blood pressure, diabetes, osteoporosis, suppression of the adrenal glands, muscle weakness, weight gain, cataract, and also glaucoma. So there's a lot of side effects, as you can see, from the long-term use of medication for asthma. And then other than the daily life complication, for disease that the patient may got from asthma, maybe pneumothorax. If the patient may have like severe asthma, the patient may got pneumothorax, because I have seen a patient which have severe asthma, then also have due to the asthma, he got pneumothorax. It is a complication lah. And then also the patient may also got lung collapse from the asthma, and also respiratory failure. Okay, I think that's all for me. Is there any question, or do we want to like?
Okay, I think we will keep the question session to the end of presentation. Continue with the next one.
Okay.
Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Izzah binti Aisyah, register number 1912940, and my topic for today is bronchopneumonia. So this is my presentation outline for today. What is pneumonia? Pneumonia is an infection of the lung parenchyma. So there is an infiltration of the interstitial tissue with the inflammatory cells. So we can say that pneumonia is a type of acute respiratory infection. When the inflammatory cells have infiltrated the interstitial tissue, the alveoli are now filled with the pus and fluid, so the breathing becomes painful and it will limit the oxygen intake. At the picture on the right side, anatomically, pneumonia we can divide into 3 types of pneumonia. First, bronchopneumonia. Second, lobar pneumonia, and third, interstitial pneumonia. As you can see, the bronchopneumonia is actually the most common type of pneumonia that occur in the children. And you can see it affects the bronchi and lobules area, but it is become a patchy infiltration. It has a spot, not in one side. However, in a lobar pneumonia, you can see it will affect the whole lobe, and in chest X-ray, for the lobar pneumonia, we can see there is a lobar consolidation. Okay, so what is actually the etiology of pneumonia? For younger children, the common type of infection is coming from the virus. However, from the older children, bacteria are the most common pathogens that will infect them. It is difficult to distinguish between virus and bacterial pneumonia in clinical practice. And this is the common pathogen that will infect kids according to their age. Firstly, newborns. Newborns are famous pathogen is coming from the mother's genital tract, usually during the intrarectum. For example, group B Streptococcus, E. coli, Klebsiella species, and also Enterobacteriaceae. For infants 1 to 3 months, the most common pathogen is Chlamydia trachomatis, and for the preschool age, it's like Streptococcus pneumonia, Haemophilus influenza type B, Staphylococcus aureus, like that. And for your information, actually, immunization with Haemophilus influenza type B and pneumococcal vaccine has markedly reduced the incidence of pneumonia from the Haemophilus influenza. So, in school age, the most common pathogen is Mycoplasma pneumoniae and also Chlamydia pneumoniae. So, the pathophysiology of pneumonia is firstly because of, for example, there is a selective failure in the kids. Like there is an inhibition of resident alveolar macrophage of the phagocytosis, or the kid itself have other immune deficiencies like HIV or cancer, or there is a repressed cough reflex, because cough is actually important because it acts as a forceful expression that can clear the airways of debris and secretion. Or other than that, there is a mucociliary impairment. So when there is a defense failure, that it will lead to a local or systemic defense failure also. So when there is a pathogens, it will that can easily infiltrate through the mucus tract of the kids. It will then enter the respiratory tracts. It will proliferate in the respiratory tract. So then it will trigger the immune system to release more neutrophils, and then there is an exudation of the protein-rich fluid, because there is and then there is the alveolar became inflamed. So when there is inflammation of the alveolar become leaky, and the capillary also it will lead to leaky alveolar walls and pulmonary capillaries. And then the alveolar that was supposed to be filled with gas is now filled with the fluid and other exudate like blood cell, fibrin, and bacteria. So the gas exchange in this patient will become impaired. That's why there is a difficulty in breathing. So what is the clinical features of pneumonia? Firstly, fever, cough, and short of breath is the most common presenting symptoms. Fever is because of the infection itself. Cough as the compensatory mechanism, and SOB. So the rapid and shallow breathing is also as an impression that the child is afraid to breathe deeply because it is pain. Other than that, associated symptom is like runny nose, lethargy. So and then the kid become restless, agitated, and irritated. And they will also have a pleural inflammation and a pleuritic chest pain that become worsened on expiration. But from that, they will have a neck stiffness if there is if the infection involving the upper lobe, or abdominal pain if the infection involving the lower lobe. So what are the signs? Firstly, from the inspection, we can see there is a grunting, air hunger, tachypnea, toxic leaking, cyanosis, nasal flaring, head retracted, and also recession around the intercostal, subcostal, and supraclavicular. On palpation, there is a decrease in the chest movement and increase in the tactile parameters because of the increase of density within the lung tissue. So on the percussion, we have like a stony dullness percussion, and on auscultation, they will have a decrease in breath sound, and they will have a bronchial breath sound, cause crepitation, pleural rub, and also increase in vocal parameters. So what is the investigation? and also the expected finding. Firstly, from the full blood count, we can expect there is an increase in polymorphonuclear cells. So if there is increase in polymorphonuclear cells, this indicate there is infection from the bacteria. However, if there is leukopenia, it means the infection is coming from the virus. Next, in a severe pneumonia or when there is a poor response to the first-line antibiotic, we can order the blood culture to determine the etiology. Next is serological test, which is performed when we suspect in atypical pneumonia such as mycoplasma pneumonia and also chlamydia. And lastly, chest X-ray that will reveal the whether there is a patchy spot or lobar consolidation, so we can see from the X-ray. Other than that is pulse oximetry, so that we can measure the level of oxygen, so that we can avoid the hypoxic. And lastly, if there is a significant pleural effusion, we can do a pleural fluid test. So for the management of the patient with pneumonia, it is divided into supportive measure and also pharmacological measure. So for the supportive measure, we can give the oral fluid intake, oxygen, temperature control by giving paracetamol, chest physiotherapy, and also cough syrup. And antibiotic, of course, to kill the bacteria. But if there is majority of infection are actually caused by virus, and we actually do not require the antibiotic. And the drug of choice is also depending on the severity of pneumonia and also cost of the drug. So what is the criteria for hospitalization? Firstly, for children that less than 3 months, whatever the severity of pneumonia. Next, if the patient have a fever more than 38.5 degrees Celsius and has a refusal to feed and vomiting, and then fast breathing with or without cyanosis, and there is another other associated systemic manifestation or failure of previous antibiotic therapy. Next is recurrent pneumonia, and lastly is a severe underlying disorder. Okay, so in the next slide is the criteria for the assessment of severity in pneumonia. So in patient age less than 2 months, so considered as severe pneumonia, and age 2 months to 5 years, you can see if there is tachypnea, so that is a mild pneumonia, or chest indrawing, that means it indicates severe pneumonia. So there is also how to know the very severe, and also in the table below is the suggested antimicrobial agent for inpatient treatment of pneumonia. So you can refer this later. And lastly, the complication of pneumonia. Firstly, the most common one is parapneumonic effusion, which is also a type of pleural effusion because there is accumulation of the fluid in pleural space. And then empyema, which is an infected pleural effusion because there is a buildup of the pus, which consists of bacteria and also dead white blood cell, and septicemia, which is also dangerous. And lastly, lung abscess because the microbial infection of the lung, resulting in the necrosis of the lung parenchyma. Okay, I think that's all from me. Thank you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Right, let me share my screen first. All right. Assalamualaikum warahmatullahi wabarakatuh and a very good evening. I am Siti Atira binti Samin, metric number 19-11316, and tonight I will be presenting about acute bronchiolitis. So what is acute bronchiolitis? Okay, so acute bronchiolitis, as the name suggests, bronchiolitis is inflammation of the bronchioles. So it's a disease of the small airway, which is bronchioles, with increased mucus production, occasional bronchospasm that sometimes lead to airway obstruction. And acute bronchiolitis, what's different from asthma and pneumonia is it is common in infants aged 1 to 6 months, up to 1 year. Okay, it's endemic throughout the year, but it peaks in the months of November, December, and January. Usually the months where the weather is much colder and then there's a lot of rain. Okay, so the causes for acute bronchiolitis, most common cause is respiratory syncytial virus, RSV. Other causes include other viruses like human metapneumovirus, parainfluenza virus, influenza viruses, adenoviruses, rhinoviruses, coronaviruses, and we have these atypical bacteria that can also cause acute bronchiolitis, which is Mycoplasma pneumoniae. Okay, so brief pathophysiology of this acute bronchiolitis is, okay, when there is infection, it will lead to inflammation. So what we know about the basic process of inflammation is there is endothelial leakage that will cause mucus production and also inflammation. So when there is mucus plug inside the bronchiole, it will cause the bronchiole to be narrowed, right? So causing difficulty to breathe. Okay, so the clinical features of infants that come with acute bronchiolitis is mild coryza, which is basically batuk sesama, low-grade fever because it's an infection, right? And also cough. And later, it can progress to tachypnea, can cause chest wall recession, we can hear wheezing, and the infant can have respiratory distress and also chest hyperinflation. Okay, on auscultation, we can hear fine crepitations and sometimes bronchi. Okay, so what's the signs of hyperinflation of the chest? Is the sternum is prominent and the liver is displaced downward, especially can be seen in infant because their organs are relatively bigger than their overall size. Okay, the ratio. Okay, next. What investigation do we need? Usually, acute bronchiolitis is diagnosed enough by physical examination and also history taking. But we can also do, especially in severe acute bronchiolitis, we can do chest x-ray. In chest x-ray, what we can see is hyperinflated lungs, segmental collapse or consolidation, lobar collapse or lobar consolidation. So it can involve a segment of the lobe or even the whole lobe. Okay, to establish the etiology, but this is not routinely done. We can do ELISA, enzyme-linked immunoabsorbent serum assay or polymerase chain reaction to look for the virus antigen. Okay, but this is not necessary to make the diagnosis of bronchiolitis. So it's not practical and not all hospitals have this facility. Also, we can do pulse oximetry to monitor the severity, okay, and the progress of patient. If patient develop respiratory distress, oxygen below 93, then we need oxygenation. Other than that, of course, we can do full blood count to make sure that it's not bacteria. Like Iza said, if bacteria, the polymorphonuclear cell count will be high. Okay, so the principal management of acute bronchiolitis is simple. It's mainly supportive. So firstly, we can give NSAIDs to control fever, and then we give normal saline for hydration. For mucus removal, we can do suction, and then if oxygenation is needed, like SpO2 is less than 93, we can give oxygen through nasal prong. Okay, if the infant develop respiratory distress, we can intubate and give ventilatory assistance. And also, patient might develop sleep apnea, which is means that they don't breathe during sleep. So for that, we need to intubate and give ventilatory support. And also for poor feeding patient with poor feeding, patient who vomit, who doesn't want to drink milk, we can put on nasogastric tube for feeding. Okay, unlike asthma, acute bronchiolitis, the bronchodilators that we use and corticosteroid that we use for asthma are seldom effective and is not generally recommended for acute bronchiolitis. So that's why it's very important to differentiate whether this is asthma or other things, acute bronchiolitis or pneumonia. Okay, what's the complication? Complication, it can lead to respiratory failure, sleep apnea, and also the mortality rate is about 1 to 2%, especially among infants with pre-existing cardiopulmonary or immunological impairment. All right, so I think that's all from me. That's the end of my presentation.
Okay, move on to the next last one.
Assalamualaikum. I will continue the next presentation. So my name is Nur Hafiza and I will continue with acute gastroenteritis and dehydration. Okay, so this is the table of the contents, which is we will discuss about definition of diarrhea, causes, and the pathophysiology of the osmotic and secretory diarrhea, and then we move on to the clinical features of dehydration, and then investigation in AGE, management, and complication. So the first and foremost, we need to know the definition of diarrhea itself. So in acute one, they have abrupt onset of 3 or more episodes of loose stool per day, and it's lasted less than 14 days. So we call it acute diarrhea. While the chronic diarrhea is, we also have the abrupt onset of 3 or more episodes of the loose stool per day, but it lasted more than 14 days. So next, we will move on to the causes of AGE in children. So the most common in children is from the virus side, which is rotavirus, and then they have adenovirus, norovirus, coronavirus, astrovirus, and pararotavirus. So this is the picture of the rotavirus. And then from the bacteria side, they can have enteroinvasive, which is the I think it's the bloody diarrhea. So they can have Campylobacter jejuni, Shigella, Salmonella, Enteropathogenic E. coli, and Yersinia. Let me check the. Yeah. So for the enterotoxigenic, we have Vibrio cholera, enterotoxigenic E. coli, Bacillus cereus, Clostridium perfringens, and diffusol, and Staphylococcus aureus. So this enterotoxigenic will cause watery diarrhea. So for the parasitic side, we have Entamoeba histolytica, Giardia lambda, Cryptosporidium species, and Cyclospora cyatensis. So we move to the pathophysiology of the osmotic diarrhea, which is one of the watery diarrhea. So in watery diarrhea, we have 3 actually. It is osmotic, secretory, and functional, but we will only discuss 2 of them today. So for the osmotic diarrhea, it's actually happen when the patient digest the substance that poorly absorb. So they actually have problem in the absorbing the substance. So it will result in the water being absorbed into the small intestine and colon. So actually in this type of diarrhea, they have the stool output, and the stool output is proportional to the intake of the unabsorbable substrate, like what they like you can see in the picture. And in this diarrhea, they will regress with fasting. And the example of this diarrhea is lactose intolerance, undigested sugar, fat malabsorption, and laxative. So we move to the secretory diarrhea, which is they happen due to the secretion of the water into the small intestine and colon exceed the total absorption. So they will cause the excess of the water and electrolyte to being absorbed into the small intestine and colon. So usually the causes of this type of secretory diarrhea is due to the activation of the pathway by toxin, or the children have the children itself have the electrolyte abnormality. So this type of diarrhea is not resolved despite you not given anything to the patient, or despite the fasting. So the example of this diarrhea is cholera, by acid malabsorption or some medication, and microscopic colitis, and the rare tumor that secrete the diarrhea producing hormone. So we move to the clinical features of dehydration. So first and foremost, we need to assess the general condition, which is in mild dehydration, the patient can be well and alert. And then we need to assess the eyes, which is the patient doesn't have any sunken eyes. And then if you offer the feed to the patient, they will drink normally. And then if you pinch the abdomen of the skin of the patient, so the skin will goes back immediately. So this is mild dehydration, which is they are actually less than 5% dehydrated, and they show no sign of dehydration. So for the moderate dehydration, for the general condition, they can appear restless or irritable, and then they have they have sunken eyes. And when you give them a drink, they will drink eagerly, or we call it thirsty. And then when you pinch the abdomen, the skin will goes back slowly. So in this type of moderate dehydration, they actually 5 to 10% dehydrated, and they show some sign of the dehydration, which is they can show more than 2 of the above sign. Okay. So for the severe dehydration, they appear lethargic, or some of the patient can be unconscious. So the sunken eye in them is more prominent, and then they are not able to drink or drink poorly. And then when you pinch the abdomen skin, the skin will go back very slowly, which is more than 2 seconds. And then this is actually, they have more than 10% dehydrated, and they show more than 2 of the above signs. So in severe dehydration, some patient can go into hypovolemic shock. So the next one is the investigation. So for the blood investigation, we can investigate the FBC, full blood count. So in the full blood count, we actually can see any sign of the infection, such as leukocytosis. And then we can order the BUSE plus creatinine, which is they can have a result of hypo or hyponatremia and hypocholeremia. And then their creatinine is usually high in severe dehydration. So the next one is we assess the serum bicarbonate, which is they will be low if the patient have metabolic acidosis. So for the last one is random blood sugar. So they usually the patient that have AGE, they tend to have hypoglycemia. So the next one is the stool one. So we can order the stool for rotavirus antigen. You can also order the stool for the culture and sensitivity, such as if you suspect the patient have salmonella, shigella, yersinia, and campylobacter. So you can also access the patient red cell and leukocyte. And if you suspect the patient have parasitic infection, so you can order these stool, ova, and cyst. So the other investigation that you can do is arterial blood gases, which is one of the complication of the AGE is actually metabolic acidosis. So this is quite severe condition. So you need to access this one. So, and then we have urine osmolality. So usually this urine will increase in osmolality if the patient got dehydration. So the next one, we move to management. So we have 3 plans. They call plan A, plan B, and plan C. So for the plan A, actually, we treat the patient at home. So before we treat the patient, the mother will be the child will be discharged with advice for the mother lah. So the mother need to do these 3 steps, which is 1, give extra fluid, continue the feeding, and then they need to observe the sign and symptom of when the patient need to return to the hospital. So in the give extra fluid, if the patient is breastfed exclusively, so they will be given with ORS or cold boiled water in addition to the breast milk. So if the child is not exclusively breastfed, so they can give either ORS, food-based fluid, or cool boiled water. So, and then it is important to advise the mother to give the ORS or in a small sip of a cup or a spoon, so that the child will not vomit everything. So if your child vomit, then you need to wait for 10 minutes and then continue, but more slowly. So you need to give this extra fluid until the diarrhea stops. So for the continued feeding, so you need to continue the feeding based on what you give the child, as if you give them breastfed, and then continue to breastfed, continue to give formula milk, and then or semi-solid or solid food, but the food with higher simple sugar should be avoided, as the osmotic load may worsen the diarrhea. So the child need to be returned to the hospital when despite the treatment that being given by their mother, when they is not able to drink or breastfeed or drink poorly, and then they become sicker over the time, and then they develop the fever, and they have blood in their stool. So for the plan B is we will treat with some dehydration with the oral rehydration solution. So we will treat some of that dehydration with the ORS, as but we will give it recommended amount correspond to the age over the 4 hours. So after you give them the ORS, as I mentioned before, that the patient need to be given slowly. So you need to reassess the child after the 4 hours and then you need to give the ORL instruction to the parent if they they cannot be admitted to the hospital, such as this give ORL instruction is from the plan A. So in the plan B, if the mother cannot admit their child in the hospital, so you need to give advice from the plan A. Okay, so for the next plan is plan C, which is in this case they have to treat the severe dehydration quickly. So the first and foremost, we need to assess the ABC, which is airway, breathing, and circulation. So, and then we need to start IV or IO immediately, and to resuscitate the patient. So the last one is complication. So this is the complication of the AGE. So from the renal system, they can have oliguria, hypovolemic shock in severe dehydration, electrolyte imbalance, metabolic acidosis, renal venous thrombosis, and hemolytic uremic syndrome. So from the CNS, they can have convulsion, or we call it epilepsy. And from the GIT side, we can have prolonged diarrhea, which is chronic diarrhea more than 14 days. So I guess that's all from me. Thank you.
Okay, all right. So do you have any question related to the presentation? Half of you are in Temeloh now, eh?
Doctor.
Betul?
Yes, doctor.
Yeah, how's Temeloh? What? Pediatric what? Is it very packed?
Doktor, kita orang tak pergi lagi pun buat sebab hari ni ada urusan dengan orientasi.
Alright, okay, okay. Just want to know what's the situation over there. Okay, other question related to the presentation. I think everything is quite clear. You'll be seeing then. I mean, at the moment, memang at least in my ward, half will be gastroenteritis, mostly rotavirus, and another half will be pneumonia, most RSV pneumonia with secondary bacterial. So you're gonna have to. I'm sure that Temeloh or in HTA at least, or even in UAE at least, will be same. So I think these are quite straightforward. You have to see the patient more, and then this is actually all the cases are common cases for short and long case. Okay, for your end of posting exam. Okay, so these are quite easy to find. So usually the question will be what we have discussed, right? What organism, pathophysiology, that's all. I think quite clear. Any question? Tak ada? Kalau tak ada, I think we end up with tasbih kifarat. So any problem? Just shut out. Yeah, okay.
I have a question for bronchiolitis and bronchopneumonia. How can we like differentiate them during history taking?
Yes, you can actually say differential. Give a differential, right? Because to accurately diagnose either of the condition is again you need a chest radiograph, right? But again, the younger, let's say less than 1 year, okay, sudden onset, fever is not prolonged, 1 or 2 days fever, okay, likely to be acute bronchiolitis, okay, as compared to prolonged fever, okay, older children, okay, usually they are more of a bronchopneumonia. Okay, so but again, this actually a differential analysis. So in your assessment, even in reality, you need to give this differential. The differential analysis is actually bronchopneumonia, acute bronchiolitis. But again, age, the younger they are, Likely it's acute bronchiolitis, especially it's a very short history, 1 or 2 days of fever. Okay, and predominantly symptom is actually acute wheezing. Again, this is actually more common in acute bronchiolitis. While bronchopneumonia more common, not to say they cannot present with wheezing, but more common, they will present with high-grade fever and presented with tachypnea, right? But again, both overlap. So if you ask me what is the most valuable, will be the age and the onset of the illness. The shorter, likely to be acute bronchiolitis. The younger, likely to be acute bronchiolitis. Okay.
Okay, doctor. Thank you, doctor.
Okay.
Doctor, I have a question about the asthma. How asthma can cause pneumothorax?
Asthma is actually again one of the what are the clinical features of asthma? It's actually wheezing, right? Or prolonged expiratory phase. Why wheezing occurred is because of the air trapping, right? And this can cause hyperinflation. Okay, why? Again, mechanics is air can go into the alveoli, but it cannot go out. This causes hyperinflation. Can you imagine? Imagine a balloon, a straw and a balloon. Okay, you breathe in, the air can go in but can't go out because of the inflammation, because of the obstruction. So you have hyperinflated lung. And then more severe form of, say, in example, status asthmaticus, where you have markedly hyperinflated lung. Okay, markedly hyperinflated lung. Then you have a risk of having a spontaneous pneumothorax. Any forms of hyperinflated lung, you can easily have a spontaneous pneumothorax. That's the primary pathology. Okay. Not just asthma. If any condition, example, airway obstruction, partial, causes hyperinflation. This also can cause a spontaneous pneumothorax. But of course, very rare. But unless you have a so-called hyperinflated, markedly hyperinflated lung. Okay, any other question?
Doctor, I have a question.
Mm-hmm.
Why is eczema the risk factor for asthma?
Okay, allergic rhinitis, asthma, and eczema. This we call it atopy condition. Okay, usually this is traditionally, classically, we say this is actually a triage of patient has, again, how you want to diagnose asthma. Everyone can come with wheezing. How can you diagnose asthma from history? Again, if there is history of eczema, history of allergic rhinitis, right? Then likely that the diagnosis is asthma. Okay, so basically it is an association because of the atopy. Atopy is actually allergy condition. Okay, because we mentioned in the first presentation how pathophysiology of the asthma, presence of a T helper cell, okay, and then presence of cytokines. So allergic rhinitis and also atopic eczema, these are actually among shared similar pathway. So it's not uncommon. Children with eczema are more prone to have asthma, vice versa. If they have asthma, likely tendency they have allergic rhinitis and also atopic dermatitis or eczema, because it's all under atopy condition. Right?
Can smoking be one of the risk factors for bronchopneumonia?
Sorry?
Can smoking be one of the risk factors for bronchopneumonia?
Yeah, it's third party or second party smoking. Yes, it's actually a risk factor. Okay, why? These are considered as actually external exposure, environmental factor, right? So in cigarette smoke, there's many what do you call this triggers, many chemicals that can trigger airway bronchospasm. So again, in children, many of these children, if those who are especially at risk, again, those with atopy condition, has underlying lung problem, right? So these usually smoke cigarette is not like it can be an acute event. Okay, I have one patient admitted yesterday because mother is away for 5 days, child is with the father, right? Nah, admitted. So when asked the mother, actually the father has been smoking at home lah. When the mother is with mana? Mak tak ada, husband smoking kat rumah kalau tak ada, takut lah. So this is actually a trigger. So the stimuli is actually many chemicals in the smoke cigarette. It create an acute bronchospasm, and usually it's not a sudden onset. Bronchospasm can be sudden, but pneumonia is actually ongoing, maybe for a few days, 1, 2, 3 days. It triggers a recurrent bronchospasm, a lot of secretion, and of course, because of secretion, you can have a secondary bacterial infection. So actually, this is actually one of the risk factor. Directly causing bronchopneumonia is difficult to say, okay? It's but causative and association, yes. But could say smoke causes bronchopneumonia? Directly, it actually triggers a bronchospasm rather than directly bronchopneumonia. The straight answer is actually association rather than direct cause. Okay. So bronchopneumonia, the common is the cause is actually infection. So likely there's an organism, but it may trigger the bronchospasm and reactivity of the lung from cigarette smoke. Okay, clear tak? Pusing lah penjawapan ke? I think quite clear lah. It's actually a trigger and risk factor.
Doctor?
No.
I have a question. For acute bronchiolitis, why are bronchodilators and corticosteroids are not effective for its management?
Because the pathophysiology it's different, right? Pathophysiology is different, but again, in practice, even when you start working, again, it's not easy to decide whether this actually acute bronchiolitis or bronchopneumonia while waiting for your chest X-ray. Not easy to get a chest X-ray immediately, you know, in clinic kesihatan, example, or even in hospital. So what you can do is actually when you heard the child is having presented with shortness of breath and acute wheezing, it's okay to administer bronchodilator, okay, as an empirical treatment. What is your duty if you are the one who order the treatment? Example, you order to give a nebulized salbutamol to this patient. What's your duty is to review the child again half an hour or 1 hour after the administration, and you document in your notes. Patient has no response, or patient has partial response, or patient has good response to nebulized bronchodilator. Okay, because you are the one who assess, and you inform the superior, and we will assess again. If in many conditions, even acute bronchiolitis, they have some response or partial response to bronchodilator. Okay, so we will administer bronchodilator even though the diagnosis is acute bronchiolitis because they actually responded to the treatment. But strictly speaking, children with acute bronchiolitis who fulfill the diagnosis from the blood, from the X-ray, from clinical, the mainstay of treatment is oxygen, because oxygen is natural bronchodilator. Okay, so why bronchodilator doesn't work in acute bronchiolitis is again the pathophysiology is a mucous secretion, right? Rather, it's actually rather than like asthma is hyper responsiveness. So that's why even if you give a bronchodilator in acute bronchiolitis, is the response is almost poor, right? So other treatment that you can use is actually in United States. In States is you use adrenaline nab, adrenaline or epinephrine rescue, but is not favorable in UK or even in Malaysia. Right? We probably use bronchodilator, or some center use the hypertonic saline like normal saline or normal saline 3% to reduce the hypersecretion of the in bronchiolitis. Okay, so it's a different mechanism and different pathophysiology. That's why they don't respond. So another theory why bronchodilator doesn't respond is again hypothesis. You can find it in many of the books and also journal. In children, again, less than 1 year, their beta-2 receptor Okay, remember that in bronchodilator, especially salbutamol, is actually beta-2 agonist, isn't it? So you need beta-2 receptor to respond. So children, in younger children, their beta-2 receptor is not what we call this much, and the response is less as compared to older children beta-2 receptor. Okay, so that's why again why in this condition they don't really respond to bronchodilator. Okay, this is a hypothesis about basically the pathophysiology that we discussed just now. So the treatment is actually again in KKM hospital oxygen, but you will see frequently they will try to give a bronchodilator. Some of them will have mixed normal saline mixed with a bronchodilator. So you'll see this mix of management, but strictly speaking, treatment is oxygen. Okay, ada lagi? Okay, alright. Kalau tak ada, kita end up with tasbih kifarah soals. The group leader nanti please email the presentation to me. You need marks, I will give the marks after this. Okay, Assalamualaikum warahmatullahi.
Thank you, Doctor.
Salam, thank you,
Thank you,
Doctor.
Doctor. Thank you, Doctor.
Doctor.
Bye.
Bye, bye, bye. Kau dah macam excited gila.